Welcome everyone who's already signed in. We're just going to give people a few more moments, given it's the end of the workday for many, to sign into the call and we'll get started. All right, so as people are continuing to trickle in and introducing themselves in the chat, I'd like to welcome you all to our 5th webinar in our webinar series aiming around enhancing care for patients with OUD and ED. The theme for this webinar is management or acute pain and withdrawal management in patients with OUD and ED. And we have a great group of facilitators today to help guide us and provide us with education and learning around this. Next slide, please. So first, we'd like to respectfully acknowledge the land on which we work as the unceded traditional territory of the Coast Salish people, including the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So I'll pass the feather over to Elder Doris Fox to truly set the intent of this webinar with an opening prayer. Over to you, Elder Doris.
Thank you so much, Isabel. Welcome everyone to the traditional unceded ancestral territory of the Musqueam people, which is where I'm coming from tonight. I raise my hands in gratitude to each one of you for coming. I ask Great Spirit to bless us all with an open heart and an open mind so that we can learn the most from each other. I ask us to keep that open mind in case there's something new that we may learn tonight. Perhaps it's said in a different way that really brings it clear to us. Those are the best kinds of lessons because then we remember them the most. I ask Great Spirit to continue to protect each one of you, to guide you and protect you, keep you safe from all harm, including the harm we often do to ourselves. I ask Great Spirit to continually take care of those in your support, in your wellness circles, the ones who stand by you, your friends, your family, your co-workers, your community members. I ask that they all be taken care of so that they can support you, so that you can get up each and every day and continue to do the good works that you do in His name each and every day, helping the people of each community where you reside. We raise our hands in gratitude to you, Great Spirit, for bringing us together in this beautiful circle. This is such important work, and we know that. So we're all grateful to be a part of this. And I'm honored to open this, to put it in the right spirit, to help us to remember that each one of us, we are here to serve, that we are here to serve the people and the communities. Each one of us is a very important, integral part of that health and caring. We need each other. We need to support each other and the work that we do so that we can do more and provide more for the people that we serve. So we raise our hands in gratitude to you, Great Spirit, for helping us to remember how important the work is that we do every day. To remember that the work that we do serves so many, because others will benefit from the knowledge that we pass on to our patients, because perhaps they may share that knowledge with someone else and encourage them to seek the help they need with pain management. It's such a thing that has grown so big in the last 30, 40, 50 years, pain management. In the old days, before the newcomers came, we had very many medicines that would be used for pain management. One of them actually was taken and used our white willow to create aspirin. And that was kind of the beginning here, I think, for understanding that medicine can come from anywhere, not just chemicals, that it can also come from plants. So thank you, Great Spirit, for bringing us knowledge, teaching us new things, guiding us in a way that can provide the most benefit for all who come seeking that help in managing our pain and our suffering. We thank you for sharing a part of your very valuable day and time with us, for coming to learn as much more. Knowledge is ours to share. It is not ours to keep, which my great-grandfather Manette always told me. It is ours to share, not to keep. So thank you for bringing everyone together and sharing this valuable information. Thank you, everybody.
Thank you, Elder Fox, as always, setting the important intent of this work, not as just education, but truly in terms of improving the care of others. Thank you again for sharing your wisdom. So I'll move on to the next slide, please. So a bit more just housekeeping before we start the presentation. So just a disclaimer that a lot of these protocols have been derived to address the quick changing nature of caring for these patients in the context of the toxic drug supply. So some of them might be outside the BCCSU guidelines. Next slide. So the intent of this webinar is that we don't just talk to you, but hope to hear some of your experiences and wisdom as well. So we want this webinar to be interactive. There'll be questions asked throughout the cases, so you can answer the questions either using the raise hand function, so we'll be keeping an eye for that, posting in the chat so we can pose a question for you. And this current group of facilitators have added another element of interaction using Mentimeter. So please have your cell phones available and handy to be able to interact in this way. And we'll talk in more detail later on. If you feel more comfortable when you are participating, please turn off your camera, but it's not required. Know that this session will be recorded, as you saw at the initial part of our webinar, and will be placed on a YouTube channel with BCCSU. These cases are really based on clinical scenarios we hope you've all encountered and that our facilitators have themselves encountered, but have been adapted for more simplicity for this particular webinar. We know we won't be able to answer all your questions during this session, so know that we will try and answer them as best we can, but those that have been missed will be answered in a post-email roundup. And at the very end, there'll be time for more question and answer of the webinar, so most of our facilitators will be around to answer. So I will pass it over to the wonderful group who will be taking the helm of this webinar.
Okay, well, good evening, everybody. We'll start with some introductions, and I guess I'll start. I'm at the top. So I'm Aaron Zaidoff. I'm an eMERGE physician up in the interior. I work in the Salmon Arm and Royal Inland, Kamloops and Merritt hospitals, and also serve as the director for Emergency Services Network in Interior Health, medical director, that is. My partner in crime here, Heather Hare, is my director. So I'll pass that on to Leslie.
Hi, everyone. I'm Leslie Lapalainen. I'm a family physician that now does exclusively addictions medicine. So I work as one of the medical leads for addiction medicine for Interior Health. And then my clinical work, I work at Kelowna General Hospital as an addictions consultant. And I'll pass it over to Sammy Clement.
Hi, everyone. Thank you so much for being here. I know everyone has very, very busy lives, especially right now, but this work is so important. So thank you. Thank you so much again for being here. My name again is Sammy. I'm a peer engagement advocate, a certified peer support worker, and a patient partner with Interior Health. I also recently started a position at the Canadian Aboriginal AIDS Network as a promising practices coordinator. And with that, I will pass it to our lovely elder, Doris Fox.
Oh, sorry. Hang on.
Doris, would you like to introduce yourself, or or should we carry on? I know you already spoke the welcome.
Sorry, is my camera on? I
It
can't
is,
tell.
yeah.
I've been having trouble with it all day, so I'm like, I can't see myself, so I don't know if it's on or not. Sorry about that. My name is Doris Fox, and I'm an elder from Musqueam. I sit on various boards of directors. I'm the president of the board of directors for Kilalalela Medical Center. I also sit on various research projects, selection committees for the medical world. Yeah, and I also have a list of clients that I help on a regular basis out over and above the work that I do out in the community. So kind of busy. I'm a mother of two beautiful daughters, amazing, incredible beings that they are, and a grandson and a granddaughter who are miracles. They're just miracles. So yeah, and I do all kinds of volunteer work in the community, and I love my life. I love my jobs. I love it all. Thanks for coming.
Thank you. Next slide, Heather. So just on behalf of our group here, we have no actual or potential conflicts of interest in relation to this presentation. Next. All right, Sammy.
So as a patient partner, I just kind of wanted to set the tone for this webinar with this lovely little definition here about structural stigma, which we all know very well. But I just wanted to remind us all that as practitioners, we can each support stigma reduction by ensuring that the people who are accessing services are treated with compassion, patience, and understanding. Many individuals who are accessing care don't have positive relationships with healthcare providers, and or they've been traumatized by experiences that they've had. Next slide. So meeting people where they're at and employing a trauma-informed, culturally sensitive approach to care is absolutely crucial in supporting the shifts that are required to address systemic barriers in healthcare and structural stigma as a whole. Next slide.
So the learning objectives, of course, we're here to learn together, as Elder Doris referenced very truly in her opening comments. The cultural safety and humility is our foundation for the work that we do in the Emerge and across the Health Authority. We're going to continue to build on the previous presentations that were done in creating and developing an approach to the management of opioid withdrawal and opioid use disorder in the Emerge. And in this particular presentation, focusing on sort of an approach to pain management in patients presenting to the emergency room with opioid use disorder. We'll discuss some challenging scenarios in which both opioid use disorder and withdrawal, and also the use of OUD therapy will be discussed in conjunction with managing acute pain. And throughout, we will be weaving the thread of stigma reduction throughout the presentation. Next slide. So a brief outline, Mentimeter, we'll discuss that in the next slide. So it's going to be a way, super helpful way just to engage everyone. So make sure you have your phones handy for the next slide. We'll be going through about 4 course cases. As the emergency physician, I'll kind of review and present the case, and then my colleagues will help, Leslie and Sammy will help, pull through the key points, and we'll hopefully come out the other end with some tidbits and some pearls that you guys can take away with you. We'll follow with the Q&A and a closing prayer at the end. So bring your phones out. Heather, can you pop to the next slide? So in your web browser, if you could type in menti.com, just give you guys a moment to do that. So just menti, MENTI.com. And it'll pull up a screen with a bar with 1, 2, 3, 4, 5, 6, 7, 8 in the bar. In that bar, if you could click on that bar, you can enter the code, which is 5226 5558. So I'll say it again, 5226 5558, right on the top there. And oh, good, some of you are all over this already. And then you just enter, you can answer the question that is posed there. So the first one, what community are you logging in from? And we'll capture a little bit of the group that we have with us today. Excellent, look at you guys are pros. Awesome. Super. Okay, so we've gotten the first question down. So Heather is going to, or Heather can refresh to the next question. So the next question we have on Mentimeter, again, we should just be able to refresh your Mentimeter on your phone there, and enter how comfortable are you with managing acute pain with a patient who has an opioid use disorder. Heather, can we pull up this Mentimeter? Oh, there we go. So, all right, so we have some not at alls, we have some maybe a bit, some confidence, and just like our Olympic team, we're suffering for gold medals right now. So that's all right. Maybe by the end we'll have a few more gold medalists, but we can maybe catch up to the Norwegians. So anyways, very good. Well, looks like we have some work to do, I must say, for across the board. These are always very challenging cases. And I think you'll see as we go through it that there are a lot of pieces to be aware of. Very much a holistic approach is needed. So Heather, can we jump on to the next slide, which is our first case? So while Heather's pulling that up, I'll begin kind of reviewing the case. So our first patient comes into our emergency department. He's a 28-year-old male who comes in with a common presenting complaint to our emergency department of a right lower quadrant pain. On our CT, we were thinking maybe appendix, but we actually found an 8mm stone in his distal ureter. So he's pretty uncomfortable. You've spoken with urology and he's going to go on the slate for the OR tomorrow, but right now he's yours in the emerge. You've given him some pain control with 15 milligrams of Toradol IV. However, his pain is still pretty out of control. He's has a history of an opioid use disorder and is currently on Suboxone. He still uses about a point every 1 to 2 days. Smokes it, and then also some tobacco. Just about 5 cigarettes a day. So as I mentioned, he's on the Suboxone 20 milligrams a day, which has been helpful for him in his journey. But yeah, now he's a hurting guy. Heather, can you switch to the next slide? So question, and this again is for your Mentimeter. So how should we manage his acute pain? Should we hold? Should we, and what about his Suboxone? Should we hold it? Should we give it? Should we change the dose? So Heather, can you switch to the Mentimeter? So in this Mentimeter question, the question that you see before you is, what would you do? Are you going to use the same dose, hold Suboxone, lower the dose, or increase the dose? This patient is going to be NPO, going to be heading to, pretty soon, going to be heading to the emergency or to the OR soon as well. So, so we want to, be aware of that course coming up. Heather, we can't see Mentimeter quite yet.
Sorry, Aaron, I also just wanted to speak to that in this question. One of the things that as a patient partner, I felt would have been lovely to have in there is educate the patient and ask the patient what they think might be a good option for them. Just during our discussions, it was one of the things that came up. So I wanted to bring it up in the meeting.
Yeah, for sure, for sure. Engaging them is such a key point, as Sammy mentioned. So we have give the same dose as the number one. We have an increase in the dose. We have a lower the dose. So it looks like we have some key points to review. So thank you, Heather. So keep your Mentimeter up, guys. We will come back to it, but we're going to jump on to the next slide, which is a review of some key points from this case, which Sammy already started to chat about. And Leslie, I'll pass the next slide on to you.
Perfect. While we're waiting for Heather, we can't quite see that slide yet, but if there's anyone who has thoughts around kind of other things that we could do for managing this patient's pain, and then we'll speak specifically on how to dose his Suboxone. So feel free to either jump on just kind of on the chat or take yourself off mute and just throw out some ideas in terms of pain management. And maybe while we're waiting to hear from you, we'll just talk about considerations for Suboxone in terms of dose range. So often with kind of higher doses of Suboxone, so this patient was on 20 milligrams, because Suboxone has such a high affinity to the mu opiate receptor, it kind of blocks the effect of other full-acting opiate agonists. And so for surgical patients in particular, we often actually lower the dose of Suboxone. So pull back to around 12 milligrams a day. And then often we'll split their dose. So 4 milligrams TID in particular for surgical patients. But if someone's really struggling in terms of pain management, you can actually pull back a bit on their Suboxone to that 12 milligram mark, and then add kind of short acting opiates on top. The one kind of key thing is previously we used to stop Suboxone. So we're like, oh, they're in acute pain, we'll just stop it and we'll use just short acting opiates to try and treat pain, but you end up kind of chasing your tail doing that. So they have this kind of opiate debt because they haven't had their Suboxone, and then you add acute pain on top. So ideally you want to continue the Suboxone, but at a lower dose, and then really go kind of back to basics in terms of non-opiate options. So acetaminophen, NSAIDs. Opiates, I think sometimes people are a bit worried about giving opiates to someone with an opiate use disorder, but they're very appropriate in a situation like this. So common kind of dose range that we would look at giving for a patient on Suboxone to start would be kind of 4 to 8 milligrams PO, Q, 1 to 2 HPRN. And then really the key is that you have to kind of reassess the patient and see how they're doing. If they get 8 milligrams and they're like, this is not touching me, I would increase by kind of 2 to 4 milligrams with each dose increase. And in particular for patients with opiate use disorder, they often have a lot of tolerance to opiates. And so the dose range that we're going to give is often quite a bit higher than we would give for patients that are opiate naive. But it's important to give opiates. Semi-synthetic opiates like hydromorphone or synthetic opiates like fentanyl seem to be able to overcome the opiate receptor blockade that Suboxone provides a little bit better than kind of more natural opiates like morphine. And then thinking, I haven't been able to look at the chat yet in terms of the questions, but
one question.
Yeah, jump in.
So it looks like oh, go ahead, Sammy.
No, go ahead.
I was just going to say there's a couple things that you brought the post or people brought up in the chat. So Dr. Ron talked about ketamine, so beyond the mu receptor. Jessica mentioned like asking patient permission to use opioids or discussing with the patient, you know, whether in together with there's any opioids. And Melissa Allen highlighted the use of hydromorph if needed rather than those other opioids you mentioned.
Yeah.
And then also Kaylee has her hand up.
Hi.
Okay,
I don't want to steal anybody's thunder. I don't know where you're headed with this, but I'm an anesthesiologist. And we have a procedure for elective surgical patients and doing a washout period for Suboxone, converting them to traditional opiates. And that facilitates pain management perioperatively from a surgical perspective. In our emergency patients, what I've found is that and the washout period can be is like a week. It's a long time. So our emergency patients, we don't even bother. There's just no point because we're never going to achieve that. So that's exactly what we have to do, is go beyond the mu receptor and then just keep giving them opiates until it's effective, which makes me feel like a total loser, but that's what we do.
No, thank you, Callie. And there was also a point, certainly IV would be a very appropriate use in this patient for medication administration as well. So thank you for that comment in the chat too.
And certainly the comment around ketamine is a really good option that the anesthetists that I work at KGH often use that in conjunction with Suboxone and opiates and non-opiates, and can be a really nice option as well. And yeah, these emergency cases are really interesting. And I think there's lots of kind of ongoing research in terms of like how to approach these patients, because particularly with Suboxone being first line now, we're seeing it so much more. And so there's kind of lots of ongoing research looking at continuing at a lower dose for certain cases versus having people come off totally. So yeah, lots of interesting research there. I think the other just kind of key points around this case is prior to discharge, the ideal would be to taper the short-acting opiates that they're getting and then titrating the patient back on Suboxone. That can be quite challenging if the Suboxone has been totally stopped, but we do now do micro-injections quite commonly, which is a nice way to be able to start someone while they're if their Suboxone is totally stopped. And then I think just a key learning point with this case is just that their OAT alone is not going to provide sufficient anesthesia. And so we need to make a plan above and beyond that. And then prior to discharge from hospital, linking them with their Suboxone provider in the community is really key so that they've got good follow-up shortly after discharge.
Maybe I'll just speak to one point to clarify. The washout period that Callie was speaking to is more of a longer term, as she was alluding to, over about a week. So in an acute situation like this, you would really want to go with the synthetic or semi-synthetic opioids just to overwhelm the mu receptors rather than stopping the Suboxone. Just cut it down and then add those opioids on top. Especially for a case like this where you're expected to likely come out of surgery, hopefully with the discomfort of a stent possibly, but hopefully not an open wound that needs analgesics such as a hernia or an appy or something along those lines. So hopefully there'll be an opportunity to get the patient back on their Suboxone quickly after surgery. All right, Heather, should we jump to the next slide? So this patient came into the emergency room, in Kamloops there sometime in the end of October, dressed as Batman, and his friend brought in this video. Heather, go ahead and run the video. So his friend wanted to show us this video just to give us an idea of what happened to him. He's a 22-year-old who took a flying leap, as you saw, and unfortunately sustained a fracture to his left ankle. It didn't require immediate operative repair, wasn't open, but he also had several rib fractures, which was, giving him some discomfort as well. The past medical history is he had started on Suboxone about 5 months ago and was actually had been completely abstinent, and recently went back to school and reconnected with his family, so was really doing well. He was on Suboxone 16 milligrams a day, and and no other medications, otherwise healthy guy. Your plan moving forward is to discharge him. You've spoken with the ortho, you got follow-up arranged in about a week, you've put a cast on his leg and have the follow-up planned, and you're looking at what to do about pain management for his ribs and his ankle. So maybe we could just take a minute to, if you can unmute yourself, you can enter in the chat, just what are some of your thoughts around management for this patient as you discharge him from the emergency room. We'll just pause to see if there's somebody typing, or anybody wants to unmute, feel free to unmute. And currently he is on 16 milligrams of Suboxone.
And it's been quite stable at that dose, abstinent for several months and doing quite well, both from an OUD perspective and also kind of socially.
Yeah. Heather, maybe we can pop to the next slide as well. Okay. Well, we have some suggestions in the chat there. So we'll but let's and Leslie, I'll pass it over to you and Sammy to discuss this key points here.
Sure. I think that the key point that comes up for me in this case is really trying to engage the patient around their hope for pain management. So some patients who have been abstinent for several months and doing really well in terms of their recovery may be really hesitant to accept opiates for acute pain control, and others may be really afraid that they won't get opiates and that they'll need to self-manage their pain if it's not adequate. So similar concepts to the last case, so maximizing kind of non-opiates, but opiates probably are appropriate for patients if they feel kind of that they would benefit from them. And you may need to try some doses in eMERGE to determine what dose range that patient's going to need to get adequate pain control. So again, I would probably start like hydromorphone 4 to 8 milligrams and see what they do with that dose. And if they have kind of a good response, great, you can kind of work with that dose range. And if you may need to titrate up higher, so I would probably titrate up by, again, 2 to 4 milligrams. And then I think the other thing that comes up that's really key is just ensuring that they have good follow-up in the community, so that you're not giving them like a 3-week prescription for opiates, which I don't think many of you would do, but just kind of giving small amounts and then more frequent reassessments in the community. And then Sammy, I don't know if you have any.
Yeah, I wanted to just jump in, and one of the things that came up in the case is that he has recently kind of reconnected with his family and his friends. So really kind of capitalizing on that piece and engaging the family in whatever support system is available, I feel would be a really appropriate way to kind of manage this. And I know that this is a little offshoot, but in my personal experience, having cannabis as an option to be prescribed from the ED, I feel like would be a really great option potentially as well.
Yeah, those are great points, Sammy. I think one of the good take homes there too is that pain is multimodal, right? It has emotional, psycho-emotional, as well as physical components, so making sure you kind of tap into all those pieces, that's excellent. I think also just for this patient, one of the, if this patient was an inpatient, sometimes maybe an elderly patient with some rib fractures, or maybe not even elderly, maybe 40 or 50, there may be some options, some good options for blocks. Certainly, Callie, our anesthesia colleague, could jump in with some intercostal blocks, or possibly even an epidural if needed. So certainly, consulting anesthesia, if it's an inpatient for MSK pain may be an option as well. So, so just something else to think about.
There was one comment, Aaron Leslie, on the use of alpha blockers, and I don't know if you thought that in the acute setting, somebody in acute pain who's on OUD, whether that might be beneficial at all. Just curious to get your thoughts on that.
Yeah, certainly you could try like clonidine. I know in like ICU settings, they use Precedex quite a bit, but I don't personally order it when I'm seeing patients, but clonidine would be reasonable. Again, just thinking about kind of how can we control pain, not just at the opiate receptor, is probably reasonable to try adding that in.
Super. Okay, next slide. So for our third case, you've just had a busy day in the emerge, and you're seeing a 30-year-old female who's presenting with a 3-day history of fever and chills, kind of nondescript, but you dig in a little bit deeper, and you're hear a bit of a murmur, and you're suspicious there may be an infective endocarditis going on here. She has a history of opioid use disorder with IV heroin and fentanyl, 5 points a day for about the last 2 years. She also injects some crystal meth, 5 points a day. You have a discussion with her, seeing as she's going to need to sort of stay in the hospital and get this worked up, get some IV antibiotics if indeed it does come to be endocarditis. And so you're concerned for her, and you want to start her on some Suboxone. She declines that, also declines methadone or Cadian. She has a blanket overhead and is having a difficult time engaging her. It's just not going that well. Unfortunately, she is pending admission by your hospitalist, but she's going to be a few hours in your care before handover happens. So what next slide. So this is pull your Mentimeter again. We're going to have a bit of a Mentimeter question here, but the question is how are you going to manage her withdrawal in the emerge, and particularly in preventing her from leaving against medical advice. I think we want to ask you the question, which principles in this case are going to be most important to consider in the approach to this patient. So Heather, we don't see the Mentimeter quite yet, but if you guys all have your Mentimeter up and running, you should have the question there, and you can click on your thoughts. Yeah, no, we don't see it yet, Heather. Okay. So,
can you give us the code again, Aaron? Mine just signed up.
I certainly can. 5226 5558. So again, 5226 5558.
I'm not sure if it's working. Mine just brings me to a game called Snuggles.
Yep, something's gone wrong. Sorry, guys. My apologies.
No worries. Okay, Heather, you could just bring us back to the slides then, and
yeah, I can't explain this. Sorry, guys.
okay.
Mine's asking me to play with Puffy.
Somebody has stolen our code. Uh-oh. Okay.
Right,
no worries at all. So maybe if you want to put in the chat, what are some things to consider in this patient, and in particular, some of the challenges that were presented in this case. So you can put them in the chat box, or you can unmute and voice. I mean, you guys are all so good on Mentimeter. We are getting great responses, so we know you have thoughts. So don't hesitate. Okay. So one question, ask her ask what she needs to, to enable her to stay.
Yeah, some great comments in here in terms of like baseline oral opiates, IV adjunct, short-acting opiates to get through withdrawal and pain management. Later discuss OAT when she's comfortable. Love it.
Ketamine as well, and hydromorphone, ketamine are coming up there again, which are really important as well.
I'm so impressed with the amount of innovation and available options. This is so great.
Right, Heather, can we pop to the next slide? Oh, and then we can jump to the next one too. We can skip that one.
Great. And Melissa also mentioned food, peer support if available.
Good.
I love that.
Excellent.
I think really you guys kind of hit on all the key points. So really, like, this is a fairly sick patient who we really want to support just in staying in hospital. And so kind of our goal for her is just kind of harm reduction to support withdrawal management and make her feel safe in hospital. So totally appropriate if someone is declining OAT or even with OAT initiation to order short-acting opiates for withdrawal management or cravings. So typically in terms of kind of common medications that I would order is I would offer to the patient like, hey, do you want morphine or hydromorphone, and give them that choice, unless there's a contraindication for morphine, like they have impaired renal function. Then kind of common dose range that I would start off with for morphine is probably in the range of 20 to 40 milligrams orally, Q1 to 2 HPRN. Or hydromorphone, again, probably 4 to 8 milligrams PO, Q1 to 2 HPRN. And then I often write like for opiate withdrawal or cravings. And sometimes if I can, I'll try and talk to the nurse that's looking after the patient and just say like, can you offer it to them for cravings? And if I'm not able to talk to the nurse, or I'm worried that they're going to a different floor and I won't be able to talk to the nurse looking after them, I'll write things like no max dose, please offer. And if possible, you want to, again, titrate up. So if their initial dose, they're saying like, hey, I'm still dope sick, this is awful, I'm going to leave, then you need to go higher. Typically, we'll start with oral PRNs. But in some really high risk patients, especially if we're really worried that they're high risk of leaving AMA and they're quite sick, it may be appropriate to give them some IV options. But what's nice with oral is it takes a little bit longer to take effect, but it is going to stay in their system a bit longer. So we'll provide kind of more longer acting coverage for them. Yeah, titration. Food can go a really long way. I know that was in the chat. And if you're unsure of how to kind of order these PRNs, it's quite appropriate to call the BC CSU 24/7 line and just kind of review the case with them, and they can provide some suggestions for dose range and titration. And kind of longer term for this patient, it will depend a little bit on your practice setting, what services are available to you. If there's a addictions consult service, I would suggest getting them involved. But if there's not, I think whoever the MRP is for that patient, their goal is really going to be to try to build rapport with the patient. And then once they're kind of more settled from an acute pain and withdrawal perspective, they can kind of re-offer them OAT. And often when people first come into the emerge, they feel terrible and they just feel uncomfortable. And then once their withdrawal has been adequately managed, they may be more kind of on board with trying OAT, especially if their admission is a direct consequence of their substance use. I think you've got some potential to use some motivational interviewing in terms of maybe talking about the benefits of OAT.
Sorry, Leslie, I just wanted to jump in here quickly, just to kind of reiterate a lot of the points that people have already said. But yeah, providing education and connecting either with community services, or if there is a peer worker available, like these kinds of situations are where peer workers, in my experience, have the most impact. And again, just asking her what she needs. And sometimes when people are in withdrawal, they just need to be alone with their symptoms, even if it is really uncomfortable. But yeah, I'm so incredibly excited about all of the different ideas and options that were here. I think, Leslie, if we're good, next slide.
Yeah, I'm just going to address a comment in the chat from Jessica, just that the Q1 to 2H is really challenging for nursing. Totally agree. I think once you have established what is an adequate dose for that patient, you could consider like a Q4H scheduled doses with PRNs in between so that they have something. It would then make it very easy to convert that patient to Cadian if they did want to switch to Cadian, and at least they're having something scheduled. You could also put them on a long acting like Cadian, but I would just be cautious with that if they're like clearly declining Cadian, and then you put them on Cadian anyways, that you just want to ensure that they're informed.
Yeah, and just so we're clear, Cadian is a long-acting morphine, just so everyone is aware.
And a treatment, like it's a treatment for OUD that we use quite commonly. So I would just be hesitant to start it if they firmly declined it already.
Yeah, and I think just in the spirit of harm reduction too, just for, we spoke, somewhat to, both the emerge and the inpatient piece, but I think in particular for emerge patients, I mean, some of these patients may have undifferentiated abdominal pain, and it could be a severe diagnosis that you're not sure of yet, but you're worried they're going to leave AMA because they just feel terrible from their withdrawal. Like really dig deep with these patients. These are might be a patient that kind of grates on you a bit, like, oh, what's going on? Take the time to talk with them. Have that trauma-informed discussion just to really feel where they're at and what they're going through, and really be sensitive to the needs, of managing their withdrawal in order to avoid the harm of them leaving with undifferentiated maybe belly pain, or in this case, a patient with a potentially severe infection. So really in your practice, be aware of the patient that is going to potentially leave AMA and find out why. And if if you can pull out something along the lines of a withdrawal that's happening, then manage it and avoid that harm of them leaving with undifferentiated or a potentially serious condition. So next slide, Heather. So this patient, you're an attending, and your resident comes to you and has a 57-year-old male that they're telling you about. He's in severe pain. The resident has done some blood work, and they've determined that he has pancreatitis, and he feels it's probably due to alcoholism. He also has a bit of hepatitis as well, with his liver enzymes being elevated over 3 times normal. He's on Cadian, 1,000 milligrams a day. His last daily dose was witnessed, and he had it in the morning. No recent missed doses. He also uses 1 to 2 points of heroin and fentanyl smoked. Alcohol use disorder. He's at about 13 ounces of vodka a day for the last 2.5 years. No history of seizures or DTs. His prediction of alcohol withdrawal severity scale, the PAUSE score, is 6, which puts him at fairly high risk for moderate to severe alcohol withdrawal. So you got quite a sick and complicated patient here, pancreatitis being clearly a very painful situation, with a fellow who's got a hepatitis and also potentially entering into withdrawal for alcohol if you keep him in the hospital, which you're hoping to do. So Heather, do we have the Mentimeter available or no? Oh, can't hear you. So
Let me try.
okay, so we'll give it give it a whirl, and
What kind of games you're offered this time?
Yeah. See what kind of stuffies you can choose from.
Probably going to access my bank account. I don't know. Let's see here.
We'll need the code again then.
So
Yeah.
so while we're waiting, while we're waiting, I think Isabel, can you pop the code in the chat again? And while you're waiting, the question on the Mentimeter, and if it doesn't come up, we still want you to enter in the chat. What are 5 words that come to mind when you think of making a plan for managing this patient's acute pain? So just 5 words. We have the, does anybody have access? Has anybody got on to Mentimeter? Oh, look at this.
It's
All right.
here.
Excellent. Okay, so 5 words. You can fill in each of the blanks and then push submit. Let's and just what do you think when you have? I'll read while you're thinking there. I'll review the case again. So you have a 57-year-old with severe pain due to pancreatitis, likely due to his alcoholism. Hasn't had an ultrasound yet, but he does drink about 13 ounces of vodka a day, and he's done that for the last 2.5 years. He has elevated liver enzymes and is he's currently on Cadian at 1,000 milligrams a day. So he's been consistent with that, but he still uses heroin and fentanyl once in a while. So complicated patient. There you go. Complex. I like it. Harm reduction. So 5 words that you come to mind. I like it. Look at that. We have patient-centered, trauma-informed care. This is great, guys. So as you enter your words, it pulls together the ones that are listed most often and highlights them. Yikes! Yeah, that's what I thought too. Excellent.
I see AMA.
That's risky. Yeah, definitely. Complicated and harm reduction. Yeah, definitely. Frustration. Need help. Yeah, I'd call too. Excellent. Okay, Heather, thank you everyone, by the way, for jumping on those Mentimeter slides. It's fantastic. So Leslie, I'll let you speak to some of the key points in this case, and Sammy as well. So
Perfect. Heather, we're not able to see the slides, but I'll just kind of jump in. So essentially the key points in this case is the patient's on Cadian, and then they're also coming in with alcohol withdrawal, pancreatitis, and hepatitis. So they have acute pain where the pause is the prediction of alcohol withdrawal severity scale. So anything over 4, they're at an increased risk of complicated alcohol withdrawal. So there's a lot going on in this case. Suggestions would be their Cadian, we need to at least provide that kind of baseline dose for them. And typically if we continue Cadian in hospital, it's good practice to call their pharmacy and verify their last dose. And ideally we cancel their outpatient prescription, but that's something that's maybe a bit more specialized, but at least just to kind of verify their last dose before you reorder it, because if they've missed a number of doses, then you need to do a dose adjustment for their Cadian dose because of potential for loss tolerance. PRN opiates is very appropriate for this patient. Often if they're on Cadian, so they're on a long-acting morphine already, I'll use short-acting morphine PRNs because then you can adjust their Cadian dose kind of throughout the admission based on their morphine use. Again, I would probably start in that like 20 to 40 milligram morphine range, but that may need to be titrated up depending on their opiate tolerance. So if they get 20 and there's minimal effect, I'd go to 30, go to 40. And if at 40, they're still not benefiting, you can titrate up from there. The biggest thing is to look at the patient in front of you and see, don't focus too much on the number, focus more on like, are they fully alert and non-drowsy? And is it effective? Yes, no. So if they don't look opiate toxic and they're tolerating the dose and they're saying that they're still in pain or they're still in withdrawal, then you need to titrate up further. This case is quite complicated with the concurrent alcohol use. So you could put the patient on a CWA for alcohol withdrawal management, but you have to be pretty cautious in terms of the overlap in symptomatology between alcohol withdrawal symptoms and opiate withdrawal symptoms. So these types of patients need to be reassessed fairly frequently, both in the eMERGE department and also kind of on an ongoing basis throughout their admission, to ensure that they're receiving benzos for things that are actually symptoms of alcohol withdrawal and receiving opiates for opiate withdrawal symptoms. And that can be quite nuanced and can be quite challenging. And so I, again, would encourage, if you had a patient and you were MRP for a patient like this, to call the BCCSU line for a bit of guidance if it's a tricky case for you. And then kind of other things that come up for me in this case is kind of longer term, once their acute pain is managed, this patient would be ideal for a Suboxone microinjection, just because of the concurrent alcohol use. It's a bit of a safer option than a full opiate agonist.
Yeah.
And I haven't had a chance to read through the chat.
Well, Leslie, I'm just realizing we're at about 3 minutes to the half hour here, so we should probably close sooner, and then we can take more questions afterwards if people want to stick around, and we can go through any of the questions in the chat there if we haven't touched base on them. So so go ahead, Leslie. You can.
You bet. So just kind of key take-home points from all 4 of the cases is that their OAT alone is not going to adequately treat pain. And then when you have a patient with an opiate use disorder who does have acute pain, really think about kind of all analgesic options, so that multimodal approach, not just opiates, but including opiates. And then offering patient choice. Often patients have had a really challenging time with healthcare providers, especially in acute care. And so it can be a really scary place for lots of our patients. So providing choice whenever available, and just having a lot of conversation in terms of how to support them through pain and through withdrawal is going to be really key. And then consult if needed. I saw Nicole put the BCCSU 24/7 line in the chat. And then on kind of discharge planning, if they're leaving the eMERGE, ensuring that they have close follow-up with their OAT provider.
Mm-hmm. Excellent. So I think Isabel, maybe we want to do the closing. Doris.
Sounds good.
Yeah.
Thanks, Erin, Leslie, Elder Doris, and Sammy for participating. Just as a reminder, everyone will be present after this webinar to answer any further questions in the chat or from the audience in a more informal fashion. And there will be our final webinar in March, and the registration link will be on our website on the BCCSU for those who are interested, and that's focusing on those other medications we use to treat patients with OUD beyond Suboxone, so methadone and Caden, which Leslie highlighted. So to close this wonderful session, I will pass the feather again to Elder Doris Fox, and that's it.
You're very good at passing the feather. I have it, see? You're magic. Thank you so much, everyone. Wow, this is just another amazing session, and I'm so honored to be a part of it. Great Spirit, I raise my hands in gratitude to you for bringing all these brilliant, beautiful minds together to share the knowledge and the things that they've learned along the way, and to be able to have a big enough heart to share it. Sharing that knowledge is so important. Like my great-grandfather said, Manette, knowledge is ours to share. It is not ours to keep. And the more that we can share what we've learned along the way, the better off it is for all of us, for the whole entire world. I want you to remember that every time you do something good and kind, filled with compassion and love, that not only are you helping the person that's right in front of you, but some of that energy, some of that love goes into Mother Earth, and she is hurting right now. She's very sad. She's doing her best, to take care of us, to continue to grow the food that nourishes our body, to take care of us, to hold the water, to make it easily accessible to all of us, which we so desperately need for life. I want you to remember that every good thought you have, because of our connection to the Mother Earth, we stand on her every day, we walk on her every day. And so that connection stays strong. That all of that good thoughts, good energy, love goes into her to help her heal. Remember, it's a reciprocal relationship. We had huge reminders this past year with the fires and the flooding and all the terrible things that happened last year. We need to help her, and the melting of our polar caps. This is huge for us. We need to remember her so that she can stay strong for us. Continue to give us this knowledge that we're sharing here today. It's so important. Remember that medication started as natural medicines and grew from there. And that's not always a bad thing. Remember, you're a part of that chain, that very important chain of medication. Not only do you prescribe medication, but the most important thing that you do for your patients, your clients, your members, whatever you call them, is the compassion and the love that you give. Being able to listen with both ears to what's going on in their life. Just because someone is in addiction does not make them less a human being than you are. Does not make them less important than you are. Every person who is in addiction has families, friends, and communities that care about them, who think about them often and want them to come home. And you're a part of that journey of bringing them home. Remember that, a very important part of bringing them home to their loved ones. So I raise my hands in gratitude to you all for doing the work that you do. I ask Great Spirit to continue to give you the courage, the strength, and the love that you need to continue to do the good work that you do each and every day. You're not alone in the work that you do. This beautiful virtual circle, we would normally be in a big circle, is proof of that. So remember that. Raise my hands in gratitude to each one of you for sharing a very valuable part of your day, your time, and your love with each one of us. Thank you very much, everyone. Have a good question and answer period, but I have to go. So love to all. Enjoy yourselves. Bye for now.
Okay, thank you, Elder Fox, as always, for setting the intent. And thank you again to all our facilitators today. It was a wonderful, wonderful session. Anybody who has questions, who wants to stay around to chat, please feel free, unmute yourself. We've got a wealth of expertise here. Certainly I learned a lot during our sessions.
There was I think this might be a good one for you, Leslie and Isabel. There was a great question in the chat that I copied, which was actually sent to me, but I think somebody had a patient who left AMA who was in withdrawal because they said only heroin works for me. And she was offered 10 to 20 milligrams of hydromorphone. I'm not sure if the person is still around who asked this question, if that was oral or IV, every 1 to 2 hours. And then, they're asking what to do in this situation. And this, of course, was in the middle of the night.
Yeah, they're so tricky. I think one of the things is like having a conversation with the patient that this is just a starting dose. And so if it's not working, we're going to titrate up. But it's hard to, both as a physician, if you don't know someone's tolerance. And so they could say like, oh, I inject 3.5 grams a day of heroin or fentanyl, but we actually don't know the purity of the drug scene right now. It's so unpredictable. And so it's always just a starting dose. And if it's not working, we'll work together to come up with a plan to support you is usually how I approach it. And then providing some choice around like whether it's hydromorphone or morphine, or those are typically the opiates that I would use, but just that this is a starting point and we'll titrate up is usually kind of my approach. If they're really high risk of leaving AMA and it's the middle of the night, I think IV PRNs are reasonable, just to try and support them in staying overnight. Although it's not ideal kind of in terms of longer acting opiate control. If they're super high risk of leaving AMA, I think that's an okay option.
I think
Yeah.
Sammy had some really good points to this too. Do you want to speak?
Yeah, I just wanted to mention that in my experience, you know, I've had many individuals kind of say that sort of thing to me. In that situation, I don't think it's as much about the physical pain or the withdrawal pain so much as people like to feel, especially when they're in active addiction, like they are in charge of what they're putting into their body, because it's one of the few things that they have control over in that situation in their life. And that the other piece, you know, a lot of times it's not, as I said, not about the physical pain, but the psychological and emotional pain, and that the whatever substance that you're using, whether it's alcohol, whether it's opiates, there's a relationship that's been built there. And so people, you know, in my experience, they like to feel, as Leslie said, that like they have a choice or an option. And if you're, as a practitioner, just saying, okay, well, this is what we're going to give you and we'll titrate it up, people are like, well, no, I know my body. I know what works for me and doesn't work for me. Heroin works for me, so I need heroin. So any sort of education, or like in this particular case, like some sort of peer support would, in my experience, is where, you know, the relationship between service provider and service user gets severed a little bit, for a lot of people who suffer from addiction. So yeah, those are kind of just some of the points that I wanted to bring up.
And I think also some of these cases, you know, if you can't, you know, through whatever, you know, means you have a patient, you know, stay in the emerge, you can negotiate, you know, or really work with them to say, why don't you leave for a couple of hours and then come back, you know, like it's like just leave that door wide open, right? And
or even just saying to them, like, if you choose to leave, you know, statistically, like, and this is just educationally, but statistically, you're likely to be back in this amount of time or something, and giving people an option, like, if you stay and emerge, these are some of your options, instead of people getting in a cab and going to their dealer's house.
Yeah. It's
I
just
often-
a,
Sorry,
go ahead. No, you go.
I was just going to say, depending on why the patient's coming into hospital, I often tell them what I'm worried about if they leave AMA. So if I'm worried that they have endocarditis, I'll tell them, like, I'm really worried about your heart. And I'm worried you might have a heart valve infection. And some people, if they don't have this type of infection treated, can die from this infection, just so that they do understand the severity of leaving AMA, depending on what their presentation is. And then just working with them, and like realistically, if they want heroin, I think it's fair to say, like, I don't have heroin. Like, we don't have heroin on formulary at our hospital. We do
Here's the
have
next best thing.
What's that?
Just saying, we don't have heroin, but we have the next best thing.
Exactly. And even saying like heroin's actually just 2 morphine molecules together. So we do have other opiates, and like, let's work together to try and support you in staying, because we're really worried about this infection or whatever it is that's going on for them.
I just maybe wanted to summarize all your great points, which I put in there, which is like a lot of this nuances around ordering can be really difficult, but it's just explaining to our patients what's going on. So guiding our patients, which can be true for all patients. And what Erin said and what Sammy said, that, you know, part of the autonomy is recognizing we can't be everything for our patients sometimes in the ED, and we can still worry about them and make sure that they're safe if, you know, at that moment, explaining everything and why in a very upfront way with an empathetic lens, that they might have to self-treat. And sometimes that's the reality because we're not able to provide beyond just the medication, and make sure that they can do that, they're safe while they're doing that. And as Erin pointed out, to create an environment where they feel safe coming back when they're ready.
I want to thank you guys all for hosting this class. For one, even as a nurse, I've learned so much from all of you. I think I struggle though with trying to get our physician partners that aren't you guys that are engaging in these kind of classes to then order or even speak to addictions consults. Speaking to a case I had earlier, addictions very much said, like, start with 8 milligrams, double, keep going if you need to. And my physician partners did not want to engage at all. And I just don't, like, how do we engage more?
Yeah, I mean, it is hard, you know, it's a culture shift that's even happening. There's different generations, you know, of physicians, you know, and I think trying your best to educate, advocating, you know, for maybe if you need to have one of the other colleagues be involved in the discussion, one of your other nursing partners. You don't want to feel like you're ganging up on somebody, but you know, really you want to, you need to care for that patient, right? You know, the patient is your number one responsibility, not the doctor. So if you need to kind of, you know, use some other avenues to kind of try and you know, advocate for that patient, then you have to. But I think the biggest thing is, you know, it's just education, you know, providing, you know, articles if they're a reader, you know, inviting them to webinars like this, things like that, you know, could be helpful. But yeah, it's a culture shift. So,
well, and to that point, Erin, the other piece, and I've experienced this in some hospitals that I've worked in and been at, but sometimes, you know, the nurses or even the patients need to speak to the directors of the emergency department and just let them know what's going on, and ask that there be more education, not only available, but mandatory. Because the more that happens, the more the conversation it's not like a webinar that you can or can't come to. It becomes part of the training that, you know, physicians and medical practitioners need to be a part of. But that's just my opinion.
I think those are great points, Sammy. And I don't know, Jessica, you know, where you're working and who, maybe if you have some physician champions. I mean, I think we all know that sort of sadly, emergency physicians tend to listen to other emergency physicians, emergency nurses tend to listen to other emergency nurses in terms of, and so, you know, hopefully there's, I mean, you might be stuck with that one incident, but then hopefully there's some, you know, I think what has happened in different places I've worked, you know, somebody finds a physician champion to start to sort of doing either some education among the physicians, or eventually go to, as Sammy was saying, go to you know, physician leaders to either institute order sets or other things that would kind of, in certain situations, almost make it mandatory to get an addictions consult, so that, you know, a patient is much more likely to get at least the you know, the doses that they need to not to be in withdrawal and be able to participate better in their care.
Awesome, thank you. Yeah, I do agree. It's definitely a culture shift, right? And it's just only on the rise, right? Like, I primarily work out of Chilliwack, and our population has just increased immensely, right? But thank you, everybody.
Yeah, and I also just wanted to say, you know, it's so challenging, especially when, you know, as a practitioner, you want to treat people who want to be treated. And a lot of people with addiction are not in a place where they want to or are ready to be treated. And then when you have that issue along with trying to convince doctors that you're working with to provide the necessary services, it can be really challenging. But I just wanted to thank you for being here. And yeah.
I think that's a really good point, Sammy, that I think sometimes as physicians, like our goals are to like fix the patient or provide, especially probably in an emerge setting, like they've got something acute, you fix it and it's a win. So like shifting our goals to like, what does the patient want or what's in the best interest for this patient, like given their goals. And that may be like your goal for that patient is just like helping them stay in hospital to have their acute care. It's not to like fully manage their opiate use disorder if that's not kind of what their goals are. It would just be like supporting them to stay in hospital. And that's a very reasonable and admirable goal for that patient.
I don't know if anybody else has any other questions. I see Leslie has unmuted herself. I don't know if there's any last words of advice. Oh, you always have good things to say, both you, Erin, Sammy. Everyone shared such great knowledge. I'm also cognizant of everybody's time and it's late in the evening. We'll allow a few more moments, but if not, we'll part. And obviously there's a last webinar and any other questions, we'll look at the chat and make sure to, if we missed them, to answer them in a roundup email afterwards. So allow a few more moments, and if not.
I think one way to address the issue of physicians who are uncomfortable is to try and bring up that this is a long-term issue, that somebody, I mean, often I've been involved in this for almost 4 decades. So there's been a lot of changes over that time, including the number of times I've had to show up to the college to be ground down. But that to then establish that rapport with the patient, if one is looking at an eventual goal of abstinence, you still have to engage them now. And if you can't engage them now, they'll disappear because they know who has the drugs. And to bring that up with the physicians, that if you can engage them now, we've got a chance. And often that doesn't have to be in some haranguing method. We're all humans.
I just wanted to chime in and say one quick thing too. Thanks, Erin and Leslie. And to Jessica, I'm also a nurse, emerge nurse, an educator, and it's just continue to persevere, continue to share those success stories. I know in the interior, it's a change of, we've been struggling to also change culture, but we're seeing changes. And just Heather on the line says, how do you eat an elephant? She's told me this a few times and I've been frustrated, but like one bite at a time, and just like continue to share those stories, continue to build those relationships, talk about things like this, and we're going to see it. You'll start to see change, and reach out to, us in other health regions, and we're all a big team and learning together. So.
I think that's actually a great note to end on, Lisa. That's perfect in terms of collaboration, and Dr. Ron's note about that. Everyone's simply a human and just looking to be cared for. So it has to be as simple as that. So with that, I will close the webinar. Again, thanks Leslie, Erin, and also Heather, which I didn't recognize, Sammy, Elder Doris, for all your hard work. This was a wonderful webinar. Good night, everybody.
Thank you, everyone.